Yeah, thanks again for joining. It's good to be back personally. I missed another week. As some of y'all may have heard before, we just had another kid who is 1 month old now, but then last week I was on a direct care service at our safety net hospital, Ben Taub, and I worked like 90 hours, which was really fun, but obviously I didn't leave a lot of space for many other things, and saw a lot of amazing patients that hopefully at some point I will organize into some case presentations for CPS and other venues. But in the meantime, I'll ask somebody to share a case if they have one. It doesn't have to be perfect. We will always just roll with the information that we have, and then two discussants to join me, please. In the meantime, I just wanted to prompt people. Sorry, just 1 second.
Hey, Arton, are you around? Would you be able to do a quick reflection on the case yesterday?
Sorry about that, everybody. Shouldn't get interrupted again. But so for while we wait for people to volunteer to discuss and share a case, actually, working on a direct care service is something that I really enjoy. Most of my clinical time is teaching on resident and student teams, but I kind of insist on doing at least a couple of weeks a year working alone with patients, because it's just very different. And I'd encourage a lot of other folks, residents and young faculty, to continue to do that, even if you have a primarily teaching role. It's just a different kind of level of connecting with patients, having to, do every single aspect of their care. And whereas when I'm working with residents, I don't want to overstep kind of and take away their primary role in the patient care. And that goes for a lot of the conversations and things that, we have with patients as well. So this week made me kind of realize and reflect on just the importance, again, of forming relationships with patients and making connections and building trust. So for our reflection, I actually wanted to ask everybody on the call to maybe take a minute to think, and then unmute yourself or share or type in a chat, like what helps you to connect and build a relationship with your patients. And then I'll share a couple of things that happened this week that I thought were good.
I guess I'll start. Hi, it's Drew. So I think the one thing that I've seen when it comes with trying to connect with patients is honestly just doing the basics of being there and being there, listening to their concerns, empathizing with empathizing with the struggle that they're doing, because there's the old aphorism that a patient is always coming to you, not necessarily in the case of like primary care or direct care, but especially like in the emergency room or if they're being admitted inpatient, that this is the probably one of the worst experiences of their life, even though it's sort of a regular day for you. And we have to understand that this is not the ordinary place where these people are going to be. So if we understand that, and if we are able to connect with something, you know, make sure that they are able to to have space to be able to talk about their concerns, then it's it certainly helps people sort of be able to process everything.
Thanks very much for sharing that, Drew. I just couldn't agree more. I think that chasm between where our patients are kind of emotionally on their worst days, right? And where we are, just another day at work, there's just such a broad rift, and it just explains so much of a lot of the barriers that get in the way of patient care, right? We can be brilliant diagnosticians. We can know exactly what to do, but if something in that disconnect gets in the way of the patient, you know, being willing to stay and get that treatment or understanding or agreeing, then what was it all for, right? So I think recognizing that difference in the emotional states and trying to empathize and bridge it is really important. Anne-Marie, connecting something outside of their medical diagnosis, learning about their grandkids, something you show them a picture of your dog, just connecting on a purely human level. I love that. This is funny, and it may not be everybody's for everybody, but I like to eat the patient's food. I don't mean like, you know, take their lunch and not leave them anything, but anytime the patient has like a bag of little candies or mints or something like that, I always like don't mind asking if I can have, you know, a piece of chocolate or a mint or whatever. And obviously it's nice to just have a snack. But I just feel like it's the reaction I get anytime that happens is always like delight. I feel like the patient just feeling like they just gave me something, right? Even if it's a small little thing, but also, you know, I think there's like this sterile barrier, right? Where I think some of y'all are thinking like, oh, is that hygienic? Is that this or is that? And most of the time, you know, unless you're talking about somebody like with C. diff or on some really bad contact precautions, like a wrapped candy isn't gonna like hurt you, right? So it's kind of it may be a little bit odd and eccentric, but that's one of the ways that I found that I can just make a human connection. Okay, we have Mario and VJ. We still don't have a case, right, Anne-Marie?
No case that I've heard of. I do have a case that I can present if no one else has a case. But I would love it if someone else had a case to present, since I just presented on Monday.
I can present a case, but it will be a little bit, I'll wing it a little bit if that's okay.
That's perfectly fine. Ori, thank you. That would be great.
Cool.
Wing away. I like that. Okay, so Ori, why don't you introduce yourself, say hi, and then we'll have Mario and VJ do the same.
Sure. So I'm Ori. I'm a 8th year MD PhD student at Columbia, and I'm matched at UCSF for neurology. So I'll be starting that in June.
Cool. Mario?
Yeah, hi. My name is Mario. I'm a 6th year medical student in Lima, Peru. I haven't been here in a while, so I'm excited to have the opportunity to discuss again. Just classes have been the same hour as the VMRs. That's terrible, but today I ended early, so I just jumped in.
Good to have you. Thank you. VJ, are you there?
Yeah, I'm happy to be here. I'm a first year medical resident from Bangalore, India. I'm currently in my quarantine after my testing positive for COVID. Happy to be a discussant here again.
I'm sorry to hear that. How are you feeling?
I'm completely fine now. I had just mild sore throat, completely doing well now.
Okay, okay. Great. Well, thank you for volunteering to discuss. Anne-Marie, do you wanna co-facilitate with me, or if you'd rather hang back, that's perfectly fine too.
I guess I can co-facilitate.
Okay, awesome. Cool. Ori, why don't you tell us about this patient, and just as always, any identifying information, please modify or withhold. And yeah, start with chief concern, and we'll go from there.
Okay, chief concern is a rash on his legs.
A rash on his legs.
You want a little bit more?
Let's hear a little bit more.
Okay, so this is an 83-year-old guy, and he has pretty poorly compensated heart failure. So he's been in and out for diuresis as an inpatient. As an inpatient, he on one of the exams, someone noticed a rash on his legs. So it's been there for about a month. He doesn't remember kind of any changes in medications or any changes in like laundry detergents. It started on his lower legs and has worked its way up to involve the abdomen. It's itchy and sometimes tender. He didn't try any topical medications to treat it. And that's where we are.
Thanks so much. So Vijay, why don't you and I pair up and tell me how you're thinking about what we've heard so far.
The presence of rash that is acute in onset, especially in an elderly. That makes me think, is it really affecting the vessels, or is it affecting the skin? Or is it an autoimmune process that is causing a vasculitic picture? Given that he has a recent heart failure, at this stage, I'm also thinking the past medical history might give us a relevant clue. So is it really has been there for quite some time, and the patient has been noticing it since the past 1 month? Presence of probably a diabetes mellitus, or is it a skin infection itself, is one thing in considering. And affecting predominantly the lower limb, not really sure how to put it, but I think the associated symptoms make it seem inflammatory, because there is the itch and tenderness. So probably there is an ongoing inflammation that is there. So that's how I think of it. So infection as inflammation would be my first differential at this point.
I think that's spot on. I think anytime we have a CPS case and we hear rash, vasculitis just shoots up to the to the top of the list, right? But this is such a common scenario, I think. And I probably have 3 or 4 patients with heart failure on my service right now, and at least half of them have abnormal skin findings on their lower legs. And I think anytime you're talking about a dermatologic abnormality, it's critical to characterize the morphology of the rash accurately, right? Whether it's just pink or red flat spots, macules, whether they're palpable bumps, papules, whether they're hemorrhagic or not, how bright red or purple they are, or if it's just pink. The tenderness and pruritus, as you said, I agree, favors a more inflammatory condition. Although what I'm keeping in mind is that a lot of times just acute edema can just make the skin itself hurt, right? So we want to be careful. Is it the actual bumps? Is it the rash that's tender, or is there just global tenderness in the lower extremities because of the edema? And then there's the pruritus, which could be secondary, or it could just be primary. It's very common to just have dry skin, and then if there's excoriation and manipulation of the skin, then the rash could actually be from that scratching as opposed to the other way around. So that's kind of a framework that I would use for thinking about this problem in terms of how to kind of gain more information. But I also just want to share what I think is probably the most common cause of a quote bilateral leg rash in a patient admitted with heart failure. And that is the fact that a lot of times when you elevate venous pressures, capillary pressures, and especially then when you have a lot of hydrostatic pressure on top of that in the lower extremities when patients stand up, and you have an 83-year-old man with 83-year-old capillaries. Is that right, Ori? Am I right to assume that his capillaries are also 83 years old?
Yes, potentially. Yeah.
Okay. A lot of times what happens is that those capillaries just break under those elevated venous pressures. And you get what really looks like a petechial rash, it's a very similar appearance to what you'd get in profound thrombocytopenia, not too dissimilar to what you might get in vasculitis. And it's just purely from elevated hydrostatic pressures in, a sort of a susceptible, more fragile capillary because of age or something else. Now, the fact that there's extension onto the abdomen, though, which is not a dependent part of the skin, right? Just breaks this theory completely as far as I'm concerned, and raises my concern for an actual, potential vascular or other, dermatologic condition. We haven't yet seen that characterization to see if this seems like, petechiae or if it's a different, morphology of skin reaction. So I think that's a good place to maybe stop and just hear a little bit more both about the context and the history, Ori, and maybe you can just take us actually through the physical exam and describe the rash as well.
Great. Okay, so his past medical history is notable for hypertension, hyperlipidemia, mild cognitive impairment, BPH, and BPH. So his medications are finasteride, amlodipine, furosemide, metoprolol, Seroquel, and atorvastatin. So he has no notable family history. Social history is notable for a remote smoking history, and he's from the Dominican Republic. He moved to the US in the 80s. He has no allergies, no alcohol use, no drug use. In terms of the exam, so the general medical exam was notable only for 1+ edema, pitting edema, or 1+ edema in the bilateral lower extremities. And the lungs were clear, heart was normal, heart exam was normal, belly was soft, non-tender. And let me give you the skin exam. And neuro, he was ANO ×3. Okay. So there was a full skin exam. I'm reading you the dermatology consult exam. So he has faint blue-gray discolorations on his bilateral temples and cheeks. His abdomen had scattered erythematous to violaceous, non-blanching macules. His back and upper extremities were clear. His lower extremities had erythematous to violaceous, non-blanching macules and thin papules. And that is the full skin exam.
Mario, do you want to go for it?
Yeah, I think I'm gonna go right into the skin exam because I think the past medical history, I don't see any information that would really make me think about something else. I don't think the meds or the social history, remote smoking history, that can predispose you to some type of cancer. Maybe could that be a paraneoplastic manifestation? But nothing comes to mind with this exam because well, the blue-gray discoloration, the temples and cheeks, I'm not really sure what to make of that. But the actual rash we were told about in the previous aliquot, erythematous to violaceous non-blanching make me think of petechia and purpura, and the fact that it's not blanching makes me think of palpable purpura. It seems that I remember it was mentioned it was somewhat painful, the rash. So I'm in that category of a palpar or purpura / a petechial rash, and the fact that it's on the lower legs and then on the abdomen makes me think of different types of vasculopathies. I think we'll always think of vasculitis. For example, in kids, henoch-Schönlein and purpura usually present with rash with a palpable purpura on the dependent areas. And I remember from one of the initial VMR episodes that you can actually see henoch-Schönlein and purpura in older patients. I'm not sure if it's this old, but thinking in that category of vasculitis, other type of vasculopathies, I think that would also be in mind. I think a CBC and different chemistry panel would and see if there's an inflammatory nature to this disease could be helpful at this point.
Awesome. I completely agree. I think that we have signaled that this is a somewhat systemic process because it's not localized and it's kind of over the extremities. And then, you know, I agree with you, non-blanching, either that means that, you know, when you press, it's not just the blood vessel. You know, if it's just the blood vessel, so either there's been destruction of the blood vessel or some other sort of like systemic process there. And then, you know, here I'm always struggle with derm a bit, but kind of when I hear rashes on the lower extremities, I definitely agree. Kind of the big branch point in my mind as an internal medicine doctor, this isn't how a dermatologist would approach it, but you know, is this some sort of vasculitis or not? And definitely when I hear things that sound like they're raised above the skin, so at least there's some, I'm thinking, you know, is this some sort of vasculitis? Because that's a no misdiagnosis, and I completely agree with you that we'd be worried about like an IgA vasculitis, you know, ANCA, you could think about cryoglobulins, things like that, certainly. And so I agree, like I would want to look at the urine, see if I saw inflammation, look at the CBC, see if I saw anything. The other thing when I hear the word violaceous that I sometimes think about is lichen planus, where you have the 5 Ps there. And so, you know, I'd be like thinking about kind of, has he had recent hepatitis screening, things like that, doing a really thorough medication review there. And then it is kind of interesting, you know, we're trying to see, does the background have any, does it affect the foreground? He moved from the Dominican Republic, but it was so long ago that there aren't very many things that I could think of that would, you know, lay dormant in the skin that long. So I think it's less likely there, although maybe there's something. And then I'm always kind of worried about in an elderly patient, could there be some sort of malignancy masquerading there as well. Sometimes leukemia can mimic systemic processes, or you can get a neutrophilic dermatitis, like a sweet syndrome, although usually I think of more like a nodular process. This sounds less consistent. So, you know, here, I think there's a lot of different things at play, and kind of getting more information about systemic processes is going to be really helpful, taking a good look at it, and then also thinking about kind of other systemic things that could be at play. Oh, sorry, I'm finished.
You want me to give some labs?
Yeah, whatever next aliquot you think is good.
Okay, give me 1 second, sorry. Just want to pull up this note. Okay. So a CBC. So whites were 6.1. Hemoglobin was 8.2 with an MCV of 98. Platelets were 246. BMP was sodium of 139, potassium of 4.7, chloride 102, bicarb 26, BUN of 26, a creatinine of 1.4 from a baseline of 1, calcium 8.5, phos 3.5, and mag 1.8. LFT, so protein 5.7, albumin 3.2. Total bili is 0.6 and direct is 0.2. And AST is 36 and ALT is 17. Perhaps what I can do is I can give you a little bit of the biopsy. Let me give you the biopsy here, and then we can, and then a little bit of the workup. Or do you want to pause here? I feel like I didn't give you very much.
Maybe actually, can I ask a couple of more questions to fill in? Is
Sure.
the etiology of his heart failure known, and how recent was it diagnosed?
It was a couple of years before, and it was believed to be ischemic.
Ischemic. Okay. And then, do you have a differential on a white count?
Yes. The white count differential is, so neutrophils are 83.8%. Lymphocytes are 12.1. Monos are 3.4. EOs are 0.2, and basophils are 0.2.
Okay, cool. Thank you. That's helpful. And then, do you have a UA?
Yes, I do. A UA. So the appearance is yellow and clear. The spec grav is 1011. The pH is 5.5. Glucose is negative. Proteins are 30. And then there's moderate blood. And the rest is negative. The micro
Was there? Yeah.
Yeah, 7 RBCs. And 98 whites. No bacteria. And I don't have any information about CAS, unfortunately.
Thanks very much, Roy. And the reason I was asking for those, pieces of information is just to kind of mimic more the real life unfolding of a case and what information is available sooner than later. So I think that maybe gives us enough to discuss, unless after the biopsy there's a lot more. Is that the case?
So let me give you the biopsy and then we can discuss. Okay, so the biopsy showed a leukocytoclastic vasculitis. Yeah.
Perfect. Thank you. All right, Vijay, take it away.
So first I'll start with the labs. So here I think we have that there's a systemic process ongoing. I think that is what we have at the end of the history. Few things that come to my mind is the hemoglobin being low. So why should hemoglobin be low for 83-year-old man is one question. Is it just because of a chronic heart failure, a chronic inflammatory process that is happening, or is there some other underlying process is one thing I would like to think. And the MCV being on the upper limit of normal, so somewhere 98. So is it, are there two multiple processes going on? So that is causing a normocytic picture is another thing that I'm thinking. The differential, since we had a vasculitis, so in case there was a high eosinophil count, that probably could have given us a possible etiology for maybe Church straws, but other symptoms don't really go in favor of like no asthmatic attacks. So they don't fit in. What is really concerning is the creatinine here. So the creatinine being 1.4 with the baseline being normal. And the bun creatinine ratio being almost less than 20 or between 10 to 20. So I would like to think, is there an ongoing intrinsic renal injury that is happening? And so for that, I look at the urine routine. So the urine analysis is showing some amount of proteinuria. So I'm not sure if this 30 is really significant or is it normal? So is it normal? I'm sure proteinuria is abnormal, but is it in micrograms? Is it 30 micrograms?
So
Not sure.
this is a UA. So so we have like 3,300. So the 30 is like
Okay.
low protein. I would
Okay.
say.
So
Yeah.
okay. Fine. So again, although it's non-specific, we have not checked for the albumin, which would be more specific for a glomerular process. But I'd still like to think there should be something happening. Um and uh, and there is blood that is what is very significant is the WBC casts and the RBC. So this makes me think that there is a breach in the glomerulus. So that is causing both the hemoglobin, the RBCs and WBCs to come out with being sterile in nature. So this makes me think it should be a glomerular process. So is it membranoproliferative? Membranous, we expect a lot of proteinuria, and given this age, it would make us think of a paraneoplastic process. So membranoproliferative is what I'm thinking, MPGN, and the skin biopsy saying a leukocytoplastic vasculitis. So I'm not sure how to make of it. So I'm thinking it is a small vessel vasculitis, as we know. So any associated features? So I would like to think of whether there's an hepatitis C serology that could help us make an association. And being hepatitis C, that can also give us a possibility of, I'm sure lichen is ruled out because of the skin biopsy here. So that is what I'm thinking of. And specific gravity being 1.101. So I'm thinking, is it a chronic process that is happening where we get an isosteinuria in the urine in a chronic interstitial process that is ongoing? So these are the thinking I have.
That's beautiful, Vijay. Thank you so much. That was really eloquent, and I think again, just really on target diagnostically. I can try to kind of clarify a couple of those questions. So first of all, I forget where I heard this. It was some podcast and somebody that I really trusted, so I like kind of kept this pearl with me. But the pearl was that think of the protein on the UA as almost like a binary screen. Okay, it's positive, it's abnormal, but it doesn't really tell you like how abnormal it is. And really, to quantify the proteinuria, you want to either get a 24-hour collection or at least a spot protein creatinine ratio to see if it's subnephrotic, nephrotic, because it again, even if it's not impressive on the UA, it could turn out to be significant in terms of the actual quantity. On the other hand, if you do get a more reliable quantitation and it's mild, just proteinuria in acute illness from any systemic inflammatory state is just common enough that it doesn't necessarily reflect like a glomerular process. However, I completely agree with you that there does seem to be a glomerular process in this case, based on the UA as well as the skin findings. I'm guessing, maybe not, but I'm guessing that some of the listeners were like, what, we're getting a biopsy result on the third aliquot? Like, don't give it away, right? And I almost like had the same reaction initially, right? But I actually think, I didn't expect to be too surprised or foreclosed by the biopsy, with the reason being that, as Anna Marie and Mario kind of said, just this exam is like so convincing for like little bleeding in the skin, right, and with the normal platelets from capillary rupture, that it really seems like there's a vasculopathy, vasculitic process in the skin. And when you biopsy one of those lesions, for the most part, what you're going to get is this answer of leukocytoclastic vasculitis, which basically just means a small vessel vasculitis in the skin. And it doesn't actually necessarily tell you the etiology of that process. Sometimes, I think about half the time, it's actually just isolated to the skin. But as Vijay pointed out, both the UA findings, the elevated creatinine, and the presence of unexplained anemia, point to this being a systemic process. And then our job is to figure out, which of the, handful of possibilities we're dealing with. So when you think of a small vessel vasculitis that involves the skin and the kidneys, my list is ANCA-associated vasculitides, IgA-mediated vasculitis, like HSP that Vijay mentioned earlier, or Mario, I think, mentioned, complement-mediated vasculitis, rheumatoid or lupus-associated disease, and then cryoglobulonemic vasculitis, which could be mediated by hepatitis C, and maybe this patient has subclinical cirrhosis that is causing the macrocytosis as well. Or half the time, cryovasculitis can actually be, non-HCV related and kind of self-driven and idiopathic as well. And then finally, a couple of rare causes. Behçet's can involve small vessels, and but the list I mentioned probably accounts for more than 90% of the cases, unless I missed something major, which please someone fill in. So I think there's some serologic workup to be done here, but unless we can do any kind of talk to the pathologist to see if there's any more details about staining and patterns in the skin, this patient might really benefit from considering a kidney biopsy in addition to the serologies like ANCAs and ANA and complement levels to actually pin down the actual pathologic process. I think there's the anemia obviously is worth working up just with routine studies too, right? Things like B12 deficiency are common enough that it could just be completely unrelated to all the other problems, but there may be a single unifying diagnosis with all of this. I'm sorry, I also didn't mention anti-GBM disease. And then both with the ANCAs and the anti-GBM, I think paying really close attention to the lungs, both symptomatically on physical exam as well as with imaging, could also clue you into kind of a subset of some of these disorders that tend to also involve the lung parenchyma.
Okay. Next, Aliguan. So just to reiterate, so on the physical exam, the lungs were clear. He had a chest X-ray that showed some like prominent vessels, but without there was no parenchymal changes. Let me give you some of the serologies now. The skin biopsy, they did immunofluorescence for a number of markers. They were all negative. Let me give you some serologies. So an HIV was non-reactive, an ANA was negative, an ANCA was negative, an RF was positive, an SPEP showed a monoclonal IgG kappa, a monoclonal IgG kappa peak. A UPEP showed a monoclonal IgG kappa and lambda Bence-Jones proteins and on immunofixation. And I think I'll stop there.
Can we do complement levels if you have them?
Yes, I do. Or I will find them. Give me 1 second. So complement C3 was 60, and let me figure out if that's normal in our lab. So C3 was low, and C4 was undetectable.
All right, Mario, what are you thinking?
Okay, I think we have a lot of new information. I think we're in a we've already entered the vasculitis realm, if you want to say so, and also because we have skin and glomerular vessel involvement. And so we're trying to find out what's the cause. And I think if we're talking about glomerulonephritis, we have three big buckets. If it's anti-GBM, immune-mediated, or post-immune. I think the post-immune and the immune-mediated would be the two categories we would be thinking about with the skin involvement. And with the low complements, I think that splits the two immune-mediated buckets into two. We were thinking maybe this would be a henotype HSP picture that usually has normal complements. So maybe that probability is lowered. And in the other bucket, it's a big list, but something that jumps up with the positive UPEP and SPEP is what monoclonal gammopathies can either directly or indirectly cause vasculitis. And for me, at least, cryoglobulinemia jumps in my differential. I'm not sure. Would this be a type 1? I think so, right? Not a mixed type. I think the mixed ones were secondary to. I'm not sure. Maybe I got that wrong. But and I think depending on the type of cryoglobulinemia, you could have different manifestations. I think one had more musculoskeletal manifestation, and the other one I had to check. I had to check that, but that's where my mind is in some type of a cryoglobulinemia picture.
I completely agree, Mario. I love that you've separated it into immune-mediated and then post-immune glomerular nephritis. And kind of the way I separate that in my mind is the complement levels, which is why I ask for it. In cases of immune-mediated, you usually have immune complexes. The immune complexes are consumed, and then you get lowering of the complement levels. So the fact that the complement levels are low points to an immune-mediated process, which Mario pointed out as well. And then I also think of cryoglobulins with that. Some of the causes of normal complements I generally think of are things like ANCA associated, and then also IgA as well will have normal complement levels, but the immunofluorescence was negative in this case. And so now I'm kind of thinking in that category. The age makes me think things like lupus and everything are less likely. Additionally, the ANA was negative, which is about 95% sensitive. So makes it extremely unlikely to be something like that. We do have this positive RF, and RF can be the poor man's cryoglobulinemia, because cryoglobulins are very difficult to collect. They have to be on ice and under specific circumstances and take a while. So if you have an RF and low complements in the right clinical setting, you definitely have to be worried about cryoglobulins, as Mario pointed out. Additionally, kind of looking back, the faint blue-gray discoloration around the temples and cheeks could be our clue. There's some extremities discoloration. Maybe that's going on. So the next thing we have to think about, if it's cryoglobulin mediated, as Mario pointed out, is what's driving the cryoglobulins. So I definitely would want hepatitis serologies here, but then we also have this clue in the SPEP. We have anemia, we have an elevated creatinine, and then we also have a positive SPEP for monoclonal IgG kappa, and on the UPEP as well. So it looks like there's some sort of myoclonal gammopathy of renal significance here. And our suspicion is that maybe this is driving the cryoglobulinemias. I honestly am a little bit weak on my type, but it seems like it's at least a type 1 or 2 here. And so, I definitely want to get cryoglobulin anemia, and then I'd want to kind of work this up further with a bone marrow biopsy. And then you might potentially, if the bone marrow biopsy is negative, consider getting a renal biopsy if you're concerned about the MG of renal significance. So those would be kind of the things I would be thinking of here. Does anyone have anything to add?
I was asking in the chat. I think I remember I learned from you, AMK, that did cryoglobulinemia present with usually lower C4 than C3? I think there was something like that. I'm not completely sure.
Anne-Marie, you're muted.
I said, is it okay if I share my screen really quickly?
Sure.
Let's see if I can. Um, So kind of thinking about complements, I made a chart for myself because I can never remember it. So here you're thinking about C3, C4, or both. C4 is easier to remember because it's just hereditary.
Are you trying?
Angie.
It's super small. Are you trying to show us the slide?
Oh, is it not?
I think we're seeing a folder, but not the slide.
Oh, sorry, I stink at Zoom. Let me try again.
Yeah, click share again and then select the actual window with the slide. There you go.
Did that work?
Yeah, now, perfect.
Yeah. So kind of C4 more than C3, you think hereditary angioedema, cryoglobulins, although C3 can be mildly decreased, which has to do with the way the complement system is activated. And then C3, think about post-strep, HIV atypical, HUS, C3 glomerulopathy, and dense deposit disease. And then you can get both. So cryoglobulins can certainly cause both as well. So those are kind of some of the things I think about, with the caveat being if they have cirrhosis and you're not producing it in the liver, that can also cause it to be low. Okay. I'm gonna try to figure out how to, okay. Can you all take over the screen again?
That was fantastic, Anne-Marie and Mario. Thank you. I guess maybe Ori, why don't we hear from you and get the diagnosis, and then we might have another couple of minutes for you to share any more teaching or to discuss a little more.
Cool. So a cryoglobulin evaluation was abnormal. It was a type 2 cryoglobulinemia. A bone marrow biopsy showed an immunophenotypically aberrant, light chain restricted but mature B cell population. So we got a bunch of hepatitis serologies, and Hep C was negative, and Hep B surface antibody was negative, core antibody was positive, and surface antigen was positive. And so what we felt in the end was that this was type 2 cryoglobulinemia from a hepatitis B infection. And we got a we got a right upper quadrant ultrasound, which showed like coarse echotexture of the liver, and then he was actually treated for his Hep B, even though the viral load was quite low.
And what happened? How did he do?
What was that?
And how did he do?
So his rash went away and got better, and I actually met him on his subsequent admission when he presented with facial edema, and he had been started on an ACE, and there was concern that this was angioedema from the ACE inhibitor, but on the other hand, this could have been a hereditary angioedema. And then that was essentially like the end of February of 2020, and he got lost to follow-up, and he hasn't been back into the hospital. So a little bit of an unknown at the end, but this case was great because I got to learn my cryoglobulinemia differential and vasculitis differential and stuff like that. So it was a good case.
Wow, yeah, amazing case. Thank you for sharing it. Did they ever get steroids too, in addition to the hepatitis B treatment?
No, so he had topical steroids and the rash improved, and without systemic steroids, yeah.
Okay, and sorry, I keep asking a lot of follow-up questions, but did the UA or creatinine improve over time? Do you know?
So the creatinine plateaued around 1.6, and he was scheduled. He had renal outpatient follow up, and then he didn't show up, or there's nothing in the system.
Wow. Mario, BJ, AMK, do y'all have any other questions for Ori or reflections?
Maybe I'll start. I thought in my mind, usually when I saw this monoclonal gammopathy, I thought that was going to be the underlying factor. So that's the hepatitis B. And hepatitis B, not hepatitis C. I think that we usually associate more cryoglobulinemia with hepatitis C. So this is new to me. So what I'm not sure is are these UPEP and benzylperin on urine, was that attributed to the cryoglobulinemia, or what was done with that?
So I think that in my head that was attributed to cryoglobulinemia. Just to also clarify one thing, you can see a monoclonal gammopathy with chronic hepatitis infections. So that was everything was thought to be under this one, all secondary to the hepatitis infection.
This is a little bit outside of my kind of comfort, but I do wonder though if there was basically an abnormal B cell population in the bone marrow, creating a single type of like a monoclonal immunoglobulins, and I do wonder whether those things can, in addition to just depositing in different tissues a la amyloidosis and causing organ dysfunction, right? A lot of monoclonal gammopathies, when they become significant, when they become are associated with a lot of sort of immunologic, immune-mediated abnormalities. Everything from autoimmune hemolytic anemia to thyroiditis to I think also cryoglobulinemia. So I don't, I'm not totally sure whether it could be related. And then the hepatitis B, I'll have to read more about. Mario, I2, associated with membranous GN, but as well as polyarteritis nodosa. But I don't know if anybody found sort of cryos from HBV. Dhruv, thank you for that. I'm excited to go through some of these things and learn a little bit more. Sukriti, do you want to just summarize some of the teaching points for us?
Can I just have one question. So whenever it is traditionally taught, at least it was there. First, Lee, thanks for this beautiful case. There is so much learning points at each level. I think that was a lot of take home for me. One question I had was, when do we actually think of sending for a protein electrophoresis? Because traditionally, whenever we have a high protein gap, when you have a high globulin gap is what traditionally is taught. So should we, when to even consider sending or thinking for a protein electrophoresis like this case? So that I think changed the way we thought of the process. So any thoughts on that? I'm not really sure how to make of that.
AMK?
Do you want to take this one? I feel like I don't have a wonderful answer, but in this case with the new anemia and elevated creatinine and then kind of immune phenomenon, it made sense to assess for that. But I would love your input, Zavin.
Happy to. I think I would say the same. I don't think there's an easy answer, and I think a lot of times, and my general sense is that most people kind of that monoclonal gammopathies and sort of plasma cell dyscrasias and disorders are diagnosed late, because so often they present with very nonspecific symptoms, right? So a lot of times the trigger for evaluation is otherwise unexplained anemia, otherwise unexplained renal dysfunction. Certainly when you have your liver tests and you have an elevated globulin gap, that's a common trigger for that. And then if you're working up amyloidosis, whether from a starting point of neuropathy, whether from a starting point of nephropathy or cardiomyopathy, I think that's also kind of where the diagnostic workup gets triggered. But I think the conceptual thing I would say is that your testing threshold to check an SPEP and free light chains should be quite low. Because if you think about it, these are relatively easy, non-invasive, not too expensive blood tests, right? And the thing you are potentially diagnosing or missing is oftentimes like a cancer, right? So this isn't a biopsy, this isn't a CAT scan, this is just like a blood draw. And I think even if your pretest probability is in the single digits %, it could still be very appropriate to go ahead and check for that. So in this case, I think there's a couple of reasons why it might have sort of been thought to order the test, VJ, whether that's, still thinking about the anemia and the renal dysfunction NOS, whether thinking about like renal sort of amyloid, although this is more of a itis, right? Or the other possibility we didn't mention, but amyloidosis can cause kind of capillary angiopathy too, right? And may manifest with certain skin manifestations and bleeding manifestations too. So I don't know what the clinicians, what Ori's predecessors and colleagues were thinking, or Ori himself, but I'm glad they got the test. I think there are quite a few reasons.
So as far as I can tell from the notes, this was just part of the initial workup that Derm recommended, like as with all the other serologies. And can I just say for 1 second that this was there was one senior resident, Richard Greendyke, who did the initial admission, and then we got him back when he was readmitted with the facial edema, and it was just a fantastic teacher. So,
Thanks, Ori. Sukriti, take us home, please.
Thanks, Ori. Thanks, everyone. So we began this case by analyzing the chief complaint, that was the rash. And we began doing this by characterizing the morphology of the rash. And Zavin told us the importance of analyzing the associated symptoms as well as the potential pitfalls whilst analyzing them. So very early on, Vijay used the itch and the tenderness of the rash to hone in on a possible inflammatory pathology. But Zavin reminded us that common things being most common, this pruritus could simply be a primary pruritus secondary to dryness of the skin, and the tenderness in the context of this patient's heart failure may simply be because of the lower extremity edema. However, what was most concerning in this patient's history of presenting illness was the rash extending to the abdomen, which was the main anomaly, and this caused us to think about what other etiologies could be at play. And Zavin also taught us that in the context of heart failure, apply base rate, and the most common cause of rash is petechiae that develops due to rupture of fragile capillaries secondary to the elevated hydrostatic pressure seen in these patients. As we began to get more information, the first thing that we did was to construct our problem representation, which is essentially three things: the context, the the clinical syndrome, and the time course. And here, the patient's background was significant for his heart failure, as well as his stay in the Dominican Republic. But then Anne-Marie reminded us that this stay in the Dominican Republic did not warrant too much importance in this analysis because such a presentation wouldn't fit in with the time frame in which we were seeing these symptoms. And we use the heart failure and the age to think about whether the rash, whether this was a malignancy masquerading as a rash, and this would be a no misdiagnosis in this patient. We also got the physical, and the physical did two things. The first was it clued us in to the specifics of the rash, and the other was it helped us recognize that this symptom was systemic and it was inflammatory. So we use the non-blanching rash to think about this as a purpuric or petechial rash, and then we use the violaceous color to think about lichen planus. And something that we were thinking ahead was a possible hepatitis screening. And so at this point, our pretest probability, both because this was a VMR and the patient's clinical syndrome was very high for a vasculitis autoimmune process. And we were really thinking about getting a UA, CBC in helping us make some progress. When we began to frame the hypothesis, we framed this case as essentially a small vessel vasculitis involving the skin and kidney. How did we get to the involvement of the kidney? So Vijay did a brilliant stepwise approach of putting together the anemia, the raised creatinine, and also the proteinuria and hematuria in the UA to hone in on a kidney involvement, and then get to whether this was and basically localize this to the glomerulus. And Zavin taught us that he learned a clinical Paul where he thought of protein on a UA as a binary screen, and that it was essential to quantify the protein on a UA with a 24 urine protein or a spot creatinine. At this moment, the way that we'd framed the hypothesis, we were beginning to develop our illness script for a small vessel vasculitis involving the skin and kidney. So these included ANCA-mediated processes, anti-GBM, complement-mediated IgA, lupus-associated cryo, and less commonly Behçet's. What would help us make progress? Was there any lung parenchymal involvement? Fortunately, in this patient, there was none. So we then used the labs and whether this was an immune or posse-immune process to make progress. So Anne-Marie reminded us that she thinks of an immune process being involved, being associated with low complement, and a posse-immune being associated with a normal complement. And in this patient, we found that his C3 and C4 was low. So this put us in the immune bucket. And then she shared with us her approach to low C3, C4. And I won't repeat it because it's up on the board in case I took some notes down. It's up on the board in case anybody wants it, but it was really good, so I don't want to repeat it. And finally, the fact that his rheumatoid factor was positive also clued us in to a possible cryo at play. And we finally layered this cryo with his monoclonal gammopathy that we saw as a possible indicator of an underlying hepatitis. And we came to this diagnosis. So it was a really great case. Thanks, everyone.
Great summary, Sukriti. Thank you so much. Have a great week, everyone. Have a great day. Thank you. So hepatitis B and cryos. Hey, is Ori, are you still there? No, he signed off. Oh, hey, Robbie.
Well, hello, my friend. How are you?
I'm good. Long time no see.
Likewise.
How you been?
How's parenting 2.0 going?
Twice as good, twice as hard.
Oh, I love that. I love that analogy. Twice as good, twice as hard. How's Steph doing?
She's great. She's
Yeah,
ever amazing.
that's incredible, man.
Um,
What's your kiddo's name?
Hmm?
What's your kiddo's name?
Ruben,
Ruben.
Simon and Ruben.
Simon and Ruben. Oh, that sounds like a delight. You're on non-teaching service now, it sounds like?
And now I'm on teaching. Last week I was on direct care.
Gotcha. Did you get any time off?
Eventually. I mean, I just had like paternity leave, so I'm
Oh, okay, gotcha.
catching up a little bit, I guess.
I see.
I don't know how closely you were able to pay attention, but I'm still trying to make sense of the some of the immunologic stuff. I don't know if you have it. I'm trying to think like with the just what is the connection between the HBV, the cryos, and the monoclonal spike?
Yeah, I don't know. I really don't. I think that it's hard not to wonder a possibility of a lymphoma driving cryo in a case like this, especially since the presumption is that Hep B is probably old and long-standing as opposed to new acquisition of Hep B. I remember doing some reading about the extrahepatic manifestations of Hep B being much more common in the few months after acquisition. PN being the driver. And I've read a couple of cases of Hep B driving cryo. And I had forgotten about them, actually found them in my notes. So I don't know, I think it's hard. It's hard because I think the most informative thing is he gets better with minimal to no therapy targeted against lymphoma, and that is intriguing. But yeah, no, I think it's an open question for sure.
Yeah.
Where's your head at?
I think if it was just the cryos, somebody posted in the chat just from Up to Date about how type 2 cryos are seen in not just HCV but hepatitis B, HIV, SLE, lymphoproliferation. But it's just that it's the clonal, but it's the B cell population that is a little bit. I don't know. It seems funky. Yeah, like hepatitis B. Would it really drive a clonal proliferation of abnormal B cells in the marrow? I don't think so. But I don't. It's very complicated.
Yeah, I'm in the same space. I feel like the urgency for an answer is mitigated by the fact that the patient gets better, but you still want to be like, what are those B cells going to turn into?
Yeah. And also, with topical steroids, the skin, regardless of what's driving it, might get better, right? But you don't know what's actually going on, I guess, in the kidney, or just like the primary process itself. Is it going to evolve and accelerate and stuff?
100%. Absolutely. Tough. It really is a very, very tough case. I just saw VJ pop in and wanted to wish you well, VJ. I hope COVID remains kind to you.
Yes.
Thank you, Ravi.
Yeah. All right, I'm going to bounce and jump back into the ER. Great to see you all. Happy Wednesday.
Bye.